Speaker is Judy Garber, who's going to talk about treatment selection for patients with BRCA mutations.
So I should finish the day by thanking the organizers for the privilege of being here. And Anne stood between you and lunch, and I stand between you and alcohol, so I'm well aware that this should not go on too long. So BRCA tumors, I'm always so pleased that these are included in the agenda. I must say I'm not sure that the information we've gained in the last 2 years has clarified for us completely whether we should be thinking of these as part of the spectrum of tumors that should not be distinguished in other trials, or whether we want to treat them separately. And I think you can think about Andy Tutt's beautiful talk before to help inform that for you. So I'm a geneticist. You have to have one pedigree in the talk. It's required. So here it is, just to remind you about BRCA1 and 2 as cancer predisposition genes that run in families, although there are now suggestions that we should be testing beyond family history to identify carriers. And if you believe that treatment might be different, of course, that would be motivating. So as Andy told us, BRCA1 and 2 are genes involved particularly in DNA repair. On the left are just, if you need a summary of the multiple mechanisms, places where BRCA1 and 2 and related genes operate, and on the right, the example of the double-strand break repair mechanism that we understand and that has been exploited in drugs that we'll talk about today. So one possibility for thinking about tumors that develop because of a deficiency in the ability to repair DNA breaks or DNA errors induced by chemotherapy would be that because these tumors cannot repair those errors, they would be more sensitive to chemotherapy. And these are old data now from MD Anderson that suggested that having a BRCA1 or 2 mutation in the top curves would make you more sensitive to killing by standard FAC treatment. Now, in the last 2 years, we have the POSH study, which is a beautiful study from the UK, where Diana Eccles and colleagues collected a cohort of young women with breast cancer, women under 40, and followed them, and only tested for their BRCA1 or 2 status down the road. So this is more of an epidemiologic study. They were managed by standard of care. And you can see in this slide that women in the study who had a BRCA1 or 2 mutation had the same outcome as women who did not. And in the triple negative subset, that is true as well. So these are not the years of debating platinum or no platinum. These are standard of care in which there really was not a prognostic difference, and therefore, based on these data, we would not be saying that we can predict outcome one way or the other for mutation carriers. And remember, of course, here the triple negatives, but we are mixing mutations. These are data from Mark Robson from Memorial asking the question, are the BRCA2 tumors different? And I think that probably they are. We know that they're generally more likely to be PR negative. This is looking at oncotype as a measure and showing that in BRCA2 tumors, you're more likely to have a high oncotype score, which would fit with tumors that you think might be dependent on a DNA repair mechanism or a mechanism other, perhaps, than ER as their primary mechanism. And these are old data from our group, just asking a question that I'm sure we all wonder about occasionally when you see that older woman you didn't expect to test positive with her ER-positive tumor. And the question there is, are all ER-positive tumors that occur in BRCA carriers truly BRCA-related, or are some of them sporadic breast cancers that occur on a BRCA background? If you just look at the sample division there, you can see that most of these tumors at least had loss of heterozygosity using old simple technologies for the BRCA1 mutation, but a subset of them did not. And so if you take the main message to me of this afternoon, which is that we have much better ways now of categorizing tumors, we might not want to assume always that all ER-positive tumors in mutation carriers are directly mutation-related. Maybe that explains outcome, maybe it does not. So knowing all of that, why are we still talking about platinum? So because the tumors primarily are driven by their DNA repair deficiency. These are the old data that first motivated a look at platinum, and up in the left-hand corner and I'm not going to use the pen, was the first BRCA1 cell line that showed it was sensitive to killing by platinum, not sensitive to killing by standard drugs, doxorubicin and paclitaxel, which led to the neoadjuvant study in Poland, looking at women with BRCA1 founder mutations in that population who received single-agent platinum in a study that was based on a regimen we had begun and showing a very high pathologic complete response rate with a single agent that propelled at least some of the interest, although the study was not fully completed by the time the next studies came along. So here are Andy Tutt's beautiful data from the TNT trial, looking at women with first-line metastatic disease, triple-negative disease, who were treated with platinum or a taxane, and then compared for outcome by those who had a BRCA mutation and those who did not. And you can see in the lower curves that on the left in the germline and on the right in somatic mutations in the tumors, and these are therefore generally not germline, that there was an advantage for platinum in the group that had a mutation. And here's another way of looking at the same data, with the germline on the left, showing that tumors in individuals with a BRCA1 or 2 mutation were preferentially sensitive to carboplatin compared to individuals with triple-negative tumors who were not. But here are the data on the right from GBRCA, on the left from brightness. So brightness, which I somehow can never remember very clearly, is a beautiful study that Sybil Leubel's group ran of metastatic triple-negative disease, which received either Taxol alone, Taxol plus carboplatin, or Taxol plus carboplatin plus veliparib. And you'll remember from Andy's talk earlier that veliparib was the least PARP binding, or perhaps the weakest of the PARP inhibitors. In this trial, 15% of each group, because of randomization, has a BRCA1 or 2 mutation, so most participants did not. And you really don't see much difference between the platinum-containing and not-containing arm in the central columns there for BRCA1 and 2. On the right is the GBRCA trial, which you remember was a slightly more complicated neoadjuvant study that included the HER2 positives as well, but in all the breakouts, it was clear that there was an advantage for platinum compared to non-platinum, but not in the BRCA-containing arm, in the non-mutation carrying arm. And here's another way of looking at those data from GBRCA, showing what I think was the counterintuitive prediction at the time, that it was not the mutation-carrying subset that benefited from platinum, but rather the non-carriers. So the explanation for this might be that having a BRCA1 or 2 mutation makes your tumor more sensitive to killing by chemotherapy that induces DNA errors, platinum or not platinum, and that only tumors that do not have that vulnerability require extra treatment of platinum, and whether there it's DNA cross-linking activity or it's alkylating activity, whatever, there are the data. So we do have a trial that has tried to look in carriers comparing single-agent platinum to standard AC. That trial at least has completed accrual, and we should have an answer in time, we hope, for San Antonio next year. And 40603, the Alliance trial, I am assured, is in process of analysis for BRCA1 and 2, so we will have another data set in which to look at neoadjuvant therapy for the question of whether platinum does or does not make a difference. At the moment, there are not very clear definitive data that we should be adding platinum to all of our BRCA carriers up front, because it's platinum and because it's therefore something that they should have. But this is therefore, I would say, no better and no worse than much of the other data we've heard summarized today, where it's just not as clear as I would like it to be. So what about the PARP inhibitors? So Andy gave a really beautiful talk about mechanism in which he distinguished between the synthetic lethality that was such an appealing biologic concept and PARP trapping, which at least is necessary before the synthetic lethality, which has been worked out by beautiful molecular biology over the last several years. Many mechanisms, however, are proposed for the role of PARP in DNA repair, so we find it convenient often to have a mechanism we like to think about, but there are many ways that these molecules are involved. Here's just a different way of showing the rating of PARP inhibitors for their PARP trapping ability. And it's, I think, since there are no head-to-head comparisons, not obvious that you can say one will be more effective than the other, or maybe this changes dosing, although I think veliparib has had a tough go and that we're not seeing it moving forward in the same way. So, oh, well, this is interesting. So we've had some, I don't know whether my slides are all corrupted or only a few, but we have seen somewhere in here are the data from, I think, unless these slides have disappeared in this version, since I've had 4 slides disappear today. But this is the Olympiad data, or at least a piece of it. Maybe it will reappear, I don't know. In the Olympiad data, you'll remember from Mark Robson's presentation that this was a comparison of the PARP inhibitor olaparib against chemotherapy of choice other than a platinum for first-line metastatic or first or second-line metastatic disease, showing a small disease-free survival advantage, which was a good thing because if there had not been one, we probably wouldn't be having this talk. This was the subset of the data that asked, did prior platinum make a difference? People have hypothesized that giving platinum first could identify those tumors that would be sensitive and might benefit from PARP inhibitors. These were not given that way. These are people who had had platinum as part of their prior treatment. You can see that in this study, the olaparib made a much bigger difference, or a bigger difference anyway, when platinum had not been administered previously. And in this study, estrogen receptor positive tumors did not benefit from the PARP inhibitor, only triple negative tumors benefited. But these were the talazoparib similar small study, which showed that there was a benefit in estrogen receptor positive tumors as well as triple negative tumors for the PARP inhibitor talazoparib in the similar design of single agent talazoparib compared to chemotherapy of choice other than platinums. And in the larger randomized phase 3 trial, this was true as well, with a similar small, as we were reminded, disease-free survival benefit for the talazoparib compared to chemotherapy, and an advantage, we're not going to do this anymore, whoops, there we go. An advantage in the various subsets, which you, I'm sure, can't see since I can't either, and an improvement in quality of life. So this was also true, importantly, in the olaparib, in the Olympiad study, where quality of life was an important difference between the PARP inhibitor and the single-agent chemotherapy. Although remember that most of the side effects of the PARP inhibitor are awfully similar to the side effects of chemotherapy, but at least there was not the requirement for intravenous administration, nor was there hair loss, but there certainly were low blood counts, and those are a bigger problem with talazoparib. Another drug that targets DNA repair and has had some attention is lurbinectedin, which in this study, this is a Spanish drug, and this was headed by Judith Balmani's group, looking at, on the left, the blue and yellow are BRCA1 and BRCA2 mutations, but you can see in this group of, in this study, which was limited to BRCA1 and 2 mutation carriers, there was activity of this drug in the metastatic setting. Where this might fit in will be challenging, I think, but at least you can see that there is effectiveness only in the mutation carriers, once again, not in other triple negative patients. I mean, so obviously, one of the questions one can ask about these drugs is, you know, how big a market is this? Is this going to be something that's worth pursuing? So I looked up the cost figures today, just thinking I ought to know this better than I do, and I found figures that said that a monthly cost of olaparib in the US, and remember that olaparib is approved on the basis of Olympiad for metastatic breast cancer, for ovarian cancer on the basis of many studies. Just announced was the activity in metastatic pancreatic cancer, and there is activity in metastatic prostate cancer. A month of olaparib is $13,400, excuse me, and the anticipated market for olaparib before 2024 is $753 million. So I guess there's enough reason to motivate some further activity in this area. And that's olaparib as a single agent. Certainly we heard from Andy about the possibility of combination of PARP inhibitors with other drugs. It has been difficult to do that with other classic cytotoxic chemotherapy, but there are a number of other mechanisms that certainly are worth consideration, and trials already ongoing with the WEE1 inhibitors and the ATR inhibitors that are certainly encouraging. This is from not one of Shireen's publications. I was amazed there was anybody else doing this, but certainly not as elegantly as Shireen's. These are just looking at TILs in BRCA1 tumors, showing, like other triple-negative tumors, there's activity. And I think Shireen gave very important observations that in ER-positive disease, this may be quite a different mechanism, but still activity. And I think we've done very little about characterizing BRCA2 tumors. We have questions about the other mechanisms of immune activity that might be quite useful for the combination of, let's say, PARP inhibitors with immune therapies. If you are a believer in the the multiple antigen theory of immune activity, you would expect that drugs like PARP inhibitors could increase the development of neoantigens and provide more targets for immune targeting drugs. That's one mechanism. The slide summarizes some others. And here's just the early data from Mediola, but Mediola is not complete. This is a combination of durvalumab with PARP inhibitor led by Susan Domchek, not yet finished, but this is an early publication. So the treatment of these tumors is exciting because there are a lot of options, and I don't mean in any way to sound skeptical. I actually think that it's amazing that we've been able, with a rare subset of patients, to pull off multiple international trials targeting these drugs, targeting these individuals with their specific tumors. And I still hope that somewhere in here is the Olympia slide to remind you of the importance of completing this trial, which should happen imminently. This was just a slide to remind us that other reasons to identify mutation carriers is so that we can remember the very low-tech issue of removing the ovaries, since it is true that when you look at retrospective data, that one of the main causes of death in breast cancer patients with BRCA mutations in the past was, in fact, secondary ovarian malignancy. What else is happening in this field? Well, there is the option of prevention. That's at least an exploration. These are the data from Australia, summarized in this review by Matt Yerglin, but from the laboratory of Jeff Lindeman and Jane Visvader, showing that rank ligand is an important molecule in the development of BRCA1-related breast cancers. Surprising because rank ligand is progesterone regulated, so perhaps not immediately obvious that this would have any contribution to predominantly triple-negative tumor development, but a very interesting series of papers showing this to be true. And now the randomized study led by the Austrian group here and Christian Singer, randomizing between the rank ligand inhibitor denosumab and placebo in BRCA1 carriers. This is a definitive phase 3 trial, so we know from Andrea DeCenzi it's possible to do that if you pick your groups correctly and use the right active drugs. Let's hope that that will be the case here. This study has been slow in getting started, but is about to begin both here, or may have just begun in Austria and is about to begin in Australia, and we're hoping to start in the US as well, and there are other sites around the world contributing. We have a small study looking at another hormone replacement option in women with BRCA2 tumors who have, remember, a predominance of ER-positive tumors. We'll see if this goes anywhere. But I did want to remember as well that much of the world is not testing for just BRCA1 and BRCA2 any longer. We've learned about many other genes that contribute to breast cancer susceptibility that we are able to test for at the same time. And in many countries, the idea of multi-gene testing is certainly catching on. That would mean that you'd be thinking about a broader group of patients in whom to consider therapeutic options and management implications. This is a trial asking, and this is through the TBC-RC led by my colleague Nadine Tung, asking whether PARP inhibitors will have a broadened range of activity in other genes that contribute to DNA repair. And since they are not all the same, it's unlikely that this will have identical activity in all of them, but perhaps we can begin to sort this out. The more we know about breast cancer, the more we know about susceptibility, the more complicated this gets. but of course, the more interesting. So we're always asking, what are we supposed to do with this information? I think the challenge here is that genetics is not going away. We are still looking at germline. For those of you who are looking at advanced disease with tumor genomics, you are finding BRCA mutations, perhaps in patients in whom you did not expect them. Only a small group of these are acquired somatic mutations. Those patients may also have tumors that are sensitive to these strategies. We need to sort them out, and then we can perhaps decide how best to treat them. Thank you.
Comments? Judy, in ovarian cancer, isn't there data showing that PARP inhibitors can be used as maintenance therapy after platinum? And if that's true, why does I think you mean prior exposure to platinum until the development of resistance?
So I think the main challenge of this is that ovarian cancer seems to be so different from breast cancer in this way. So it molecularly looks similar to triple-negative breast cancer, to basal-like tumors, but the biology of ovarian tumors seems to be quite different. You know that patients can be challenged and re-challenged with platinum and still have activity, that platinum resistance can be overcome. There's data that patients who become resistant to their PARP inhibitors, some subset of them will still respond to platinum. So it is quite different in that setting, not only in inducing but maintaining remission with PARP inhibitors has been very active, and the magnitude of response is greater than breast cancer in every study, I'm afraid. You know that AstraZeneca just announced, surprisingly, that the activity in pancreatic cancer as maintenance therapy in BRCA carriers is also seen. So there is, and we know that pancreas tumors have quite different biology, although I don't think that the BRCA2 version has been as well characterized. But it's just, unfortunately, not a model that has extended to breast cancer in the same way.
Any other questions? I guess that brings this session to an end. Thank you.